is liver with metastasis, liver, renal, brain, and D10 vertebral body. Next, please. Patient presented with 2 months back. Patient developed cough with remain throughout the day. She taken treatment from the local hospital. It was associated with less amount of sputum. After 15 days, she developed breathlessness. On sitting also, she had breathlessness on sitting also. Second complaint she had, patient developed chest pain left side. It was mild, continuous, dull, boring, sometimes cutting type, no aggravating or relieving factor. It was continuous throughout the day. NRS
We can't hear you, Dr. Vinay.
Was 6/10, for which she went to increase on pain also, increase on. Am I audible now?
Now
Am
you
I
are
audible
audible.
now?
Now you are.
My internet connection is somewhat unstable, ma'am. She had developed pain also in the upper back, increase on sitting down, and relieved on lying down. Pain also increase on forward bending. NRS was 6/10. Pain is stepping in nature, no burning, no numbness. And she has also decrease in sleep and appetite. Next slide, please. Patient has hypertension, for she is taking medicine for loss. She was no history of diverticulitis. There is no history of any allergy, major surgery, except this gallbladder surgery. She is postmenopausal, 30 years back. Personal history: vegetarian, non-smoker, and non-alcoholic. Change, please. Patient is conscious, cooperative, lying on the bed. Pallor positive, cloving positive, pleural effusion positive, JVP not raised, no apparent lymphadenopathy, no obstruction is feature of superior vena cava obstruction is there. CVS S1 S2 normal, respiratory system, right side breath sound normal, left side absent. In CNS examination, cranial nerves normal, motor system normal, sensory normal. On bronchoscopy, upper respiratory tract normal. Which bleed on time. On ultrasound in the liver, 1.7 segments. X-ray is there. On CT examination, there is on D10 vertebra on the body, there is 10 by 10 change please. Change please. Treatment and significant investigation. HV was 12 gram, 12 gram per DL, WBC 4.8.4, blood urea 24.7, serum creatinine 0.60, BTCT was normal, SGOT, SGPT within normal range, blood sugar was also within normal range, sodium, potassium, and chloride and calcium is within normal limit. Please. About her genogram, about her family. She had two male child and one female child. Her husband is alive, and elder son was 44 years, and second number son was 40 years, and third number 38 years. Patient is along with her husband, elder son, and elder grandson in the hospital. Patient is fully satisfied with her life. She has everything in life. She has firm belief in God. Patient knows that she has some serious problem. For that, she is taking treatment, but she was not aware that she has carcinoma in the left lung. But she is thinking that there is something which is serious and which is treated by the doctors. Caregivers are well aware of that disease progression, but wants she should not have pain. Change, please. She was on WVRT 30 grade 10 fraction for 2 weeks. Green fluid 30 ml TDS. Injection dexamethasone 8 mg TDS. Tablet oxymark, that it is codeine 30 mg with paracetamol 6 hourly. And tablet calcium is BD, she is taking BD, and injection zoledronic acid 4 mg in 100 ml of normal saline in 15 minutes. And she is taking vitamin D in the form of Erectidol Nanopack weekly, syrup Primefin plus 3 TSF-HS and capsule pantoprazole. And I have given erectile block for it, and her pain was somewhat relieved in the chest region. Change, please. Her main concern was patient want to go home and wants further treatment at home. Patient wants that she should be free of pain. Caregivers want that she should have minimum suffering, at least she should not have pain. Please. In summary, 78 years female, presenting with CA left side lung, squamous cell carcinoma with metastasis, brain, liver, renal, and lymphatic lesion in the D10 vertebral body with hypertension. Change, please. Discussion point. Pathophysiology of bony metastatic pain. Treatment of bony metastasis. Thank you, ma'am. Am I audible, ma'am?
Yes, sir, you are.
Yes, very much. Yeah. Okay, so Dr. Bijli, do you have any take on this case?
Dr. Vinay, I just wanted to ask a question first. How is she with her breathlessness now?
With the oxycodone, she was somewhat relieved. It was I think 1 month back. I have taken this case, and she was somewhat relieved from pain because pain was also aggravated.
So is she still at the hospital?
By the pain also. Then the third. Hello.
Yes, Dr. Vinay.
Yes.
Is she still
You
at the
heard,
hospital?
ma'am, what I have said? No, ma'am. She was discharged and she went to home.
Oh, okay. So that is
and
good.
After that, she will be coming for next time. I think in this week, next week, she will be in hospital for Johnny test of pain coming. But she was relieved at that time. And erectile spinal block also given her relief. That's why I didn't put her on morphine. But I think this time I have to put her on morphine.
And she's still on Dexa, right? She's still on Dexa?
Hello? That's why I was given her for brain metastasis. And also it is covering also the bony metastasis pain also.
Sorry, I need to just...
Okay, anything else, Dr. Bijli, you want to add to the management and the symptomatology that has been shown? Rajlakshmi, can you share the screen once again?
Yes, ma'am.
Yeah, the slide which had these symptoms actually. Yes.
That is first one, ma'am.
These are the presenting complaints. Can you go to the next slide? Okay, next slide, please. Next slide. Okay. So, yeah, next slide. We had some symptoms that has been given. Which was that one? I think before the previous slides, right? One. I think presenting symptoms had good symptoms. The next slide. Next slide, Rajvit. Yeah, okay. So, Dr. Bijli, you want to just add something to this slide, or you want to have any comments on this particular slide? Hello? Hello?
Ma'am, I can hear you, Dr. Bijli. Can you hear Dr. Sangamitra?
She's not audible. We can't hear you, Dr. Bijli.
Dr. Bijli, can you hear us?
Okay. I think she has a bad net connection, maybe. Okay. So she can hear. All right. So let us just go to what were the physical complaints, because bone pain has a lot of pathophysiology involved in it, because it is the most difficult pain to be managed.
Yes, sir. Yes, sir.
Yeah, in a cancer patient. Maybe we can have a discussion in the later in some other classes, but I think I want to basically understand how this patient has been managed, and what are the anticipations that we need to do for this patient, and what kind of advice will be given to the patient or the caregivers when the patient goes home. Because whatever happens at one point of time at home also, the pain may not be very properly managed. It might, increase in spite of medications. And that is what disturbs us, us to say the palliative care physicians, when we generally start managing bone pain. Excuse me. So I can see that, this patient has developed cough, and that is attributed definitely to the pleural effusion. That is one. And secondly, the increasing metastasis inside the lungs. And as you can see, it is mentioned that it was with less amount of sputum. And definitely, hello?
Hello.
Yeah. Am I audible?
Yes, sir. Yes, sir.
Okay. Okay. So as we can see, there's a production of less amount of sputum. So you see, here we will have to actually anticipate perhaps a lot of breathlessness for this patient, because once the patient starts cough, and along with the increasing pleural effusion plus the the lung metastasis, I think we will definitely need to work upon the non-pharmacological management of breathlessness. Even before, it starts, we'll just need to start with perhaps some sort of nebulization at home, which is definitely possible. A plain steam inhalation for this patient will definitely impart little bit of chest physiotherapy for this patient. You can actually ask them, ask these kind of patients to do a little bit of breathing exercises, train them on pursed lip breathing. If you know that, the pursed lip breathing is very easy for any patient to understand. And you can just show them, even when you are, doing a kind of a video consultation with such patients, you can show them the importance of pursed lip breathing and why we need to do that. And, whenever they feel breathless, even for a second or a minute also, you can, give them some sort of guidelines. What I do generally, I I have to tell my patients that there is a metastasis in their lung. There's some sort of problem that is going on in their lung, because of which breathlessness, dry cough, irritating sort of feeling on the, lower part of the throat, dryness of the mouth, all these things might happen. And those things generally, we see it in the evening hours or when the patient goes to bed, So you can actually give them a guideline sort of thing to these patients or their family members that they will need to anticipate these things. And according to that, preventively, we can start them on chest physiotherapy. But if they don't have a nebulizer, we can ask them to do a very simple, warm steam inhalation, maybe before going to bed and after before going to bed, and then after getting up from the bed in the morning. So twice a day steam inhalation for these patients work very nicely. And even if there is some sort of breathlessness, impending breathlessness, that is generally lowered down for some period of time. We can defer that to happen for some period of time, and that can impart some sort of relative comfort for the patient at that point of time. Secondly, cough is something which is very irritating because it is dry, and that generally gives the patient a feeling of why मेरे छाती में बहुत सारा कफ जमा हुआ है और वो निकल नहीं रहा है. They have a feeling of kind of a claustrophobic feeling. So what we can do, we can, as Dr. Vinay, you have rightly advised this patient about the codeine, I think codeine and paracetamol, right? A combination. So I generally give codeine linctus or, a syrup called Codilex, which has rain in it. And it gives a kind of a, it produces cough suppression for that patient, and is very, very useful for dry cough. And generally, normal expectorants or normal cough syrups do not work in such patients. So as we know, morphine generally reduces cough. It works in the, so codeine being an opioid also acts in the same manner. So a locally acting codeine linctus, codeine syrup, codeine based syrup generally takes care of it. Of course, we will need to anticipate that at one point of time, codeine may also not work. So this is about the cough and the breathlessness for anticipation. But later on, when the breathlessness increases, which is definitely going to happen at one point of time, we will have to put the patient on low dose morphine. Yeah, low dose morphine. And we generally start from 5 mg 4 times a day or 6 hourly. And that works good for the patient, as it, the mechanism of action and all. So that is one. And continue with the physiotherapy or the non-pharmacological management of breathlessness. But having said this, we all have to be aware of one fact, that oxygen is not at all the choice of treatment in these kind of patients. You may be pressurized by the caregivers कि सांस नहीं आ रहा है, oxygen देना पड़ेगा. But you will have to keep your calm, use your communication skills, be very frank with the patient's caregivers. The oxygen is not going to work. It is just a placebo. And there is every chance of the patient getting psychologically dependent on oxygen. So, you'll have to reinforce that particular thing, because oxygen will have its own side effects, it will create another problem. It's going to create a whole lot of problems for the patient if the patient is totally dependent on oxygen, which we generally see in such patients when they are in the hospital or admitted in the ICU, or putting the patient on BiPAP and everything, and then the tendency of the ICU doctors or the ICU staff to put the patient on ventilator if the patient fails to breathe. So these kind of issues will crop up with this particular patient. I'm sure about it. So Dr. Vinay, kind of a word of caution on this particular thing. You will need to talk to the family as and when required, as often as possible. Maybe you can, what I generally do, of course, you have your own work, but then still, you can prioritize your patients in that manner and, give them that therapeutic communication, which is very important both for the patient and for the family. The explanation to why these symptoms are occurring and where these symptoms are going, actually, where the patient is being led to. So anticipation in palliative care is extremely important, because I generally say that I have all the tools with me, but I'm unable to help you because of these reasons. But then, having said this, I can actually make you aware about what is going to happen next, what we all as the family and as the family's physician, what we should be anticipating. And at that point of time, how are we going to manage our patient? So, you've got to get the family members on your side so that you are able to better manage the patient. So yes, so this is about the breathlessness. Coming to the pain, you've said the patient has developed chest pain, the left side chest pain, and also the mid chest, which is continuous, dull, boring, cutting type. And there is no aggravating or relieving factor, okay? And RS 6 on 10, which she was sent to Mandi Medical College. Okay. So for that, I think you have used a block, is it? Dr. Vinay? Used a block, I think. Hello? Can't hear. Dr. Vinay? Yeah, you're muted actually. Okay, so, so for the left-sided chest pain, I will suggest, not codeine, but straight away to morphine maybe, because anyway, we're going to put the patient on morphine. Just try to find out a chest pain with the history of, metastasis to the lungs generally gives us a pain of nociception as well as neuroception. So you can actually expect a mixed kind of a pain where you can use morphine. And having said this, there are renal things also, renal issues to be dealt with, because there is metastasis to the kidneys also. I can see that in your next slide, you have mentioned about the renal parameters. Creatinine is good, but then you might have to expect a rise in creatinine later on, But having said this, I think the breathlessness is going to overpower all other symptoms in the long run. if I may say so, because that is what we can anticipate. That is what is generally seen in these kind of patients, because the lung metastasis is far more aggravating than any other symptoms here, any other symptomatology. Even if there are liver metastasis, which perhaps we may anticipate some kind of icterus later on. But having said this, the breathlessness will be the only problem here, which I can see that we should be anticipating. Yes, Dr. Bijli, you've raised your hand.
Ma'am, can you hear me?
Yeah.
Creatinine, ma'am, if I remember, was 60.
Is it 60 or is it 0.60?
Oh, did I misread? I thought it was 60. I don't know.
Yeah, it's 0.60, right?
Oh, sorry, I could not read it.
yeah, because yes, because at that point of time, I mean, if it was 60, then the whole scenario would have changed, isn't it? And you can see the SGOT and PT, they're also very, they're very little raised actually, not very much. I would say it's on the safer side, even if it is they're raised. So I will not actually anticipate any kind of, any problem with the liver also. I would say even if there are renal mets, the kidneys are on the safe side. So we are, we can use opioids. And if I say opioids, has to be morphine, oral morphine. Oral morphine can be safely used because these parameters are normal. But definitely we'll need to check on the liver and the kidney profiles, perhaps on a weekly basis or at an interval of 10 days. So that we are on the safe side, and then we go ahead with that. So that is another one. And the lastly, I think the bone metastasis. I would attribute the chest pain also to be a part of the bone metastasis, because there might be some kind of radiating pain from that part of the vertebral body to other parts, directly to the front of the chest. That might be another, you can anticipate. I mean, you can always think, assume that there is a radiation factor, which is going to be problematic in the long run. There's very little information about the bone mets, but then still, perhaps when the vertebral column is involved, we can generally anticipate some kind of spinal cord compression at one point of time. This might be an anticipation that might happen at any point of time. So it's good that zoledronic acid has been given, although the calcium is also not very problematic here. So maybe Dr. Vinay? Hello? Dr. Vinay, are your queries? I think he's left it or I'm not sure about.
I think, ma'am, he just left. He might be trying to reconnect.
I think so, yeah. Dr. Mahesh, I can see you. You have any questions on this particular case? Hello? I think he is also traveling, maybe coming back from work. I'm seriously sorry about this today, actually.
Hello, good evening.
Yeah, good evening, Dr. Mahesh. Good evening.
Yes, I'm hearing all of you,
okay.
But still I'm driving, so no problem. Continue your...
No, I completely understand. I am really sorry for you know, doing
No,
this.
no, no, not at all, ma'am.
I have a class from actually 6:30, 6:45 actually. I have to attend meeting. Okay. All right. So, Dr. Vinay, you are there. So I have prioritized your cases, you know, history and the anticipation of symptoms in the near future and how those should be dealt with. I think breathlessness is going to be more problematic for her. So, you know,
Hello.
yes, yes.
Hello.
Yes, Dr. Vinay, please go ahead. Hello. Hello.
Ma'am, I think his network is really bad.
Yes, yes, yes. I think. Okay. Anybody else want to actually join in here? Dr. Bijli, you have a question?
Not a question, ma'am. I was just wondering that this bone pain, like
Yeah.
you said, it could lead to a neuropathic type of pain sometime also, no? That the vertebral.
Yes, yes, absolutely. You can actually, you know, would be because see, bone pain is generally, you know, kind of a nociceptive and neuropathic mixed pains. So you can actually anticipate both of these components to be mixed with bone pain also.
Right. So she will probably need something for that also, no? Maybe like a, I don't know, pre-GABA or something along with
I
the
think, see, generally bone pain is, it better responds to dexamethasone, which has already been given. But I would not suggest injection dexamethasone 8 milligram TDS. I would actually suggest a single shot of dexamethasone in the morning. And that would be, you know, a high dose dexamethasone around 16 milligrams per day for around 3 days, and then taper that dose down. So that can be, that should be done actually. But because if this is TDS, that means an evening dose of dexamethasone is also there, and the evening dose will generally interfere with sleep. So that would be another problem for this person, for this patient. So I would not suggest that. We generally give dexamethasone, you know, around 16 mg for bone pain, 16 mg single shot, and then, you know, zoledronic acid is already been given. I believe that is a monthly dose, which has been mentioned here, and that generally takes care of the you know, the bone pain, and also prevents hypercalcemia. So, and of course, I think.
So, ma'am, sorry.
Hello.
Yes, Dr. Sangamiti.
Yes, yes.
Can she not put on an oral dose of dexamethasone? I mean, why do we need injection?
Absolutely. I completely agree with you. I was actually waiting for somebody to say this. Yeah. So we can actually put her on an oral dose because she's already, you know, taking all medications orally. So we do not want to put her anything on IV or IM or, you know, even subcutaneous until and unless she's very morbid, you know, and even if she's morbid, we would not want to give her anything IV. I would suggest all subcutaneous injections for her. it has equal distribution and absorption rate as IV. So I would suggest subcutaneous. But as of now, definitely, oral dexamethasone, and that can also be given in a higher dose. Of course, you'll have to take care of the gastro problems also. Along with that, the gastritis and everything. So you need to put her on pantoprazole. I think I was already using pantoprazole, and then bone pain should always be a combination of medications. I generally put my patients on, after reviewing the pain, of course, put my patients on high dose paracetamol, which is 1 gram for, every 6 hours, if that is required. But generally, I have seen a combination of paracetamol plus dexamethasone generally takes care of the pain if it is detected early, if you are actually taking care of it early in the disease. But having said this, if that doesn't work, then definitely we need to go to the the other medications, which are generally not opioids, but then the NSAIDs. And NSAIDs, of course, I do, depend on paracetamol and a low dose NSAID. You can use ibuprofen, you can use, agents like Voveron. So these can be used. And then, of course, you'll have to be aware about the kidney profile, because that is where everything goes wrong. So once you take care of those things, put the patient on all protection which is needed from the side effects of these medications, you generally capture bone pain. But having said this, it is the most difficult pains to be addressed and most difficult pains to be taken care of. But I think, yes, with experience, you have a good control over the bone pain. We can actually discuss a case. If I have one, I can discuss this next week, maybe. I have a patient with bone pain. We can discuss that. Where we have used more methadone, actually.
Methadone, ma'am, of course, the renal functions are all right now.
Yes, we can use that.
And what about, sorry, I have so many questions. I just keep asking.
No, please go ahead. Please.
Do these diclofenac patches work in these cases, or are they for just mild pain?
I haven't used diclofenac patches because, you'll not be able to monitor how much the pain has been taken care of. Because they will release diclofenac in one particular dose, and whether that is actually taking care of that particular pain, I am not actually sure about it. So I would like to put her on periodic doses to maintain the blood level. Maybe 200 milligrams of brufen, or paracetamol 1 gram for 6 hours, and see how she's been how she's reacting to it. So I would actually want to use not patches, but then tablets, of course. And then you will need to, the most important point that you need to follow when you manage bone pain is reviewing the pain all the time. If you do not review the pain, you'll never come to know what is happening to the patient, how much the pain is being relieved, what are the other symptoms that are coming because of the treatment or because of the pain itself. So these things need to be, you have to review the patient. As any other pain, if it is morphine responsive, then you are a little bit at peace that, yes, I've given her morphine. So, every 4 hours, itna to manage ho jayega. But then when it is bone pain, excuse me. So you'll have to review maybe after every 24 hours or something. Hello, Dr. Vinay?
Yes, ma'am.
Could you hear what we were discussing actually? I'm not sure because you have a very bad connection today.
I have missed maximum.
Oh, you missed it? Okay.
I could hear only last part.
Okay. So, okay, maybe next time we
only his name only.
Oh my God.
Now my internet connection is stable now.
Actually,
so ma'am, she also consultation with pulmonary medicine people because they send it to the this patient was perfect. So
Dr. Mahesh, I missed maximum of the question.
Also with nebulization.
Actually,
we can't. I sincerely can't actually make out what you are actually trying to tell.
actually, hello.
Yes.
Hello.
Yeah, Dr. Mahesh. Yeah.
Yeah. If we are talking about the bone pain, if someone consider about the palliative radiation, the response is very good.
Hello.
Yes, yes, absolutely.
Because if it is concentrated to a particular vertebral column point or something, so palliative radiation will reduce the doses of medicine.
That's true. That's really true. So I think it's already been given in this patient.
In
10 fractions of radiation has been given to this patient. And, even when we are anticipating, spinal cord compression because of, vertebral column metastasis, then also a single shot of, radiation can be very useful for impending spinal cord compression. That can be very useful. So I think that has also been mentioned in Dr. Vinay's presentation.
Thank you.
Yeah. Anything else? Do we have another case today?
Hello.
Yes. You have another case today, Dr. Mahesh?
This patient was also.
No, ma'am, no.
Okay.
Hello.
Yes, Dr. Vinay, please go ahead.
Hello. She was also given, ma'am, Taylor breast also because she has chances of fracture spinal cord. And what you was asking about dexamethasone, ma'am.
Yeah.
She was, because she had metastasis also, liver metastasis also, and all, that's why she was given that much dose of this dexamethasone. And it was started from radiation oncology side. And I usually give dexamethasone 4 to 8 mg in normal courses. If there is capillary edema is there, then I increase TDS also at that situation. Otherwise, in maximum time, if I give dexamethasone, it is in dose of 2 to 8 mg. Only in spinal cord compression and in brain metastasis there is chances of visual acuity is there, then it is given in the 24 mg. But it was started from the radiation department. So because I see the patient along with that there was. Hello.
Okay.
Could you hear me?
So maybe you will need to, if you are taking care of the pain of the patient, then perhaps you'll need to, perhaps you need to communicate with your colleagues in radiation regarding, a single dose of dexamethasone. Because orally also you can actually go on to 16 milligrams of tablets. Okay.
It should be taken before 2 p.m. Otherwise, it will hamper the.
Yeah, but then if that was if the TDS dose was given only because they they anticipated some kind of spinal cord compression, then even in spinal cord compression, there is a high single dose single dose of dexamethasone given. Okay, so around 16 to 30, even we sometimes go up to 32 milligrams also.
Yes.
32 milligrams single dose of dexamethasone with proper gastric precautions. So that can be given. Yeah. Yes. That can
second part is that erected spinal block is very good for these.
Sorry, I didn't get you.
Hello,
come again. Hello?
Hello, ma'am.
Yes.
Ma'am, erected spinal block is very much helpful in these patients.
Okay. Yeah, that was what I was wondering. And unfortunately, I don't have much knowledge about the blocks.
Yes,
so,
this is very good, ma'am. That block is for this. The second, that I want in spinal cord or fracture tissue, I want to reduce pain to 80 to 90%. Because if pain is 100% relieved, then there is maximum chances of fracture also.
I see. Okay.
And it should be prescribed with proper precaution that there is chances of fracture also because bone is fragile. So if there is some part of pain is remain there, so it can hint about the ongoing fracture.
Okay. Yeah, so that's a new insight for me. That's excellent.
Because it is overrestricted, it is over chances of fracture. Because we are also simultaneously giving zoledronic acid, and after 1 month, in 1 month time, it will cure somewhat. And also because that time I didn't give this morphine because some part of the pain is taken by the radiation also. Pain part.
Okay.
Because after 15.
Can you repeat, ma'am? Voice is not clear. Can you repeat what he is saying?
Hello.
Ma'am, in 2
Vinay sir,
weeks
voice
time,
is not clear. Kindly repeat it.
Ma'am, in 2 weeks time, the radiation also is the pain. That's why that time I didn't start with the morphine. Because erected spinal block and oxymark, both have taken care of the pain very well.
So, Dr. Mahesh, what Dr. Vinay has just described is that he has used a combination of radiation therapy along with erector spinae blockade. All right. So I'm not aware of the blocks that anesthetists generally use or pain specialists generally use for such kind of pains. As far as I'm concerned, I generally use dexamethasone for breakthrough pain and dexamethasone for bone pain and anticipate some bit of breakthrough pain also because bone pain generally is a major source of breakthrough pain. You can anticipate any kind of breakthrough pain at any point of time because of any reason, generally in such patients. So that happens. So we need to take care of the bone, the breakthrough pain also. That is one important thing that I actually perhaps mixed out on this. But what he has mentioned is about radiation, the 10 fraction radiation that has already been given to this patient, along with, the erector spinae blockade of the muscle, So those things have actually taken care of the pain that was already there, and perhaps reduce that to some extent. And the remaining amount has to be taken care by medications. I think that is what Dr. Vinay was trying to tell us. Am I right, Dr. Vinay?
Yes, ma'am. Yes, ma'am.
Yeah, yeah.
Yes, yes, excellent.
Yeah. Okay, so
and one thing, ma'am.
Yeah.
Is there should be a pain felt by the patient when bending down. Otherwise, there is chances of fracture also. If patient is not feeling pain on bending, it will surely lead to the fracture of the spine.
No, I didn't get you. What to use? Can you repeat?
Ma'am, this somewhat in flexion when the patient is flexing himself, there should be pain. It should not be treated to that extent that patient might not feel pain on bending forward. Because if patient won't feel pain, then there is maximum chances of fracture spine or something like or affection of
Dr. Vinay, in my team, we have a physiotherapist who generally uses the spinal brace for such patients, especially with patients with metastatic cancer, prostate cancer, with total perhaps involvement of the whole vertebral column with metastasis. Whatever metastasis, how much metastasis is there, he generally uses a spinal brace for these patients to be used, especially for, around 12 hours in a day, so that, the patient while, working during the day, carrying out his daily activities, there will be a point where, he's unknowingly bending also. And that might create some kind of problem later on, which are really very right. So, we cannot generally stop them from carrying out their daily activities. We want them to be doing that, isn't it? That is what is quality of life is all about. We want them to, function as much as possible. And that is going to give them a lot of, kind of mental strength, so that, they are carrying out their activities as well as pain-free, as well as they are protected from the impending problems because of the net. So that is why our physiotherapist advises a spinal brace for such patients. So that spinal brace generally protects them. So perhaps, if this particular patient of yours has just, only one vertebral column, which is there, one vertebral body which has a metastasis, you can advise her to use a belt, a lumbar belt or a kind of a cervical belt if it is not very painful, difficult for her to take it. If she has a, a size can be given to her, that would protect her from that, because that is also restrict her on the movement, and that will surely take care of the breakthrough pain. So that these things generally fall under the non-pharmacological approaches to bone pain management. You can surely do that.
Yes, sir.
And please never advise your patients on doing some, hot fermentation, because that increases the metastatic or the activities of the oncocells, and sorry, and that might be problematic. I generally ask my patients to give cold compress to such areas if they have pain, right? And that also works for them.
Okay.
That's a suggestion. Like even the physiotherapist in my team, he generally doesn't advise any kind of hot fermentation, hot compress for any of our patients. He uses cold compress for them.
Okay.
So any other query? Dr. Bijli is very silent from a long time.
Interesting. I was about to suggest, can we give a heating pad? So you answered that question.
Okay. No, we tend to do that, we generally, even when I was not in practice with palliative care patients, we definitely advised, I mean, for normal orthopedic patients, hot fermentation and, molten wax, all these are very good sources of, heat, what to say, pain management, So, even when you have muscle cramps, those hot fermentation work a lot. Very nice. But then when these are metastatic, cancer related, we shouldn't be using hot pads. That is what yeah. Okay. I think, we had a good discussion today. If we had missed something, we'll cover it next time. I'll try to present one of my cases, which I'm looking after as of now. So we can have a more discussion, actually kind of disturbing you all the time. You'll have new experiences with every patient that you get. And every patient with bone metastasis, bone pain, will have different manifestations. That is the problem with that, actually. So that is why it's difficult to manage, and that is why the approach to such patients will be individualized. Of course, for all other patients are individualized, but then for bone pain, it's much more kind of broad, and you can say quite bad-eyed in these patients. So I think that is the that is the uh, that is the challenge that we have to face with bone pain.
Ma'am, do you have time for another question?
Of course, definitely. Please tell me.
So I knew of somebody who was taking high dose dexamethasone, and he had these intractable hiccups. Nothing worked for him. They gave him Mucane gel, then they said you try Solacid and all kinds of acids. Pantop he was taking.
Yeah.
But the day he would have Dexa, he was like just he would have hiccups. He tried all those other, breathing into a bag. Everything he tried, but nothing worked. So I was wondering if in your experience you've seen something that actually works.
Actually, I have not heard about dexamethasone inducing hiccups. I'll actually look into the literature for this. But having said this, if it might be some, hiccups coming because of some other reason. And when you have intractable hiccups, the drug of choice is baclofen.
Baclofen.
Yeah.
I read about that, but I suggested it to him, and I didn't know anything about palliative care then.
Okay.
So how do you give this? I mean, have you seen it actually work, or is it just theoretical?
No, baclofen, you can definitely use it for intractable hiccups. Please go ahead and use it because it is, you should start with 5 milligrams TDS, thrice a day. Maybe you start with BD, for intractable. And when we say intractable, it's like, it's coming all the time. It's all the time. It's not able to control it by anything else. And that's going to cause a lot of distress for this patient, and even with interfering with feeding and everything. So that for that 5 milligrams BD, start with 5 milligram BD. You can increase up to 10 milligram TDS. That is that can be done. And generally, I've seen patients getting better with baclofen. They respond very well. But I'll definitely look into this issue, look into this new thing that dexamethasone might induce some kind of hiccup. I'll surely look into it and get back to you. Next time I'll definitely get back to you.
Great, thank you.
Yeah. Okay. Okay. So can we stop for today?
Or I'll have more questions.
Hello?
Hello?
Yeah, Dr. Vinay and Dr. Mahesh, can we stop for today?
Yes, ma'am. Yes, ma'am.
Okay.
Ma'am, one thing I also add carry on to intractable hiccups also. Along
with dexamethasone, did you say?
No, ma'am. No, ma'am. Baclofen.
Okay. So, right. So, yes, I'll definitely look into the cause of hiccups because of, usage of high dose dexamethasone. I'll look into that and I'll surely get back to you next in my next class. Okay. So,
is it intractable or intermittent?
I think Dr. Bijli mentioned about intractable hiccups because of Dr. Bijli, you mentioned about intractable, right?
And it's a weak dose of dexamethasone. And the day the person had dexamethasone, he would have hiccups non-stop.
Non-stop. So when it is non-stop, I would not say it is intermittent, it is intractable. And intractable, it doesn't need to be period specific because it might start and then it doesn't stop. And when we say intermittent, then perhaps there is a point where the hiccups will stop and then again start after a period of rest, So I would, I would say whatever Dr. Bijli has described, it is intractable hiccup. And interestingly, there is a history of taking high dose dexamethasone. So we are linking dexamethasone intake to intractable hiccups. So I'll look into it and then get back.
Thank you.
Okay. Okay, so thank you so much for bearing with me today because I changed all your timings.